Can you hear it now?
Just should text me. Just say check. 1, 2, 3, like 2 times, and then.
Yeah.
Good afternoon, one and all present here today. I hope you all are as excited and enthralled as we are. Welcome to Kovid Epignosis, Fight the Infodemic. I'd like Nagesh sir to give us a brief introduction and about today's event, and also share a few kind words with all those present here today. Sir, please do the honor, sir.
Good afternoon, everyone. Thank you, Gaurav. This COVID pandemic brought many challenges from the last, and we are all actually affected in one or the other way, and a lot of confusion, and to some extent, actually, we have overcome that previous pandemic, the first wave, what was so-called first wave, and now again the second wave. With lot of again that apprehension. We thought actually the first wave it will almost like we came out of this pandemic and we've gone to normal life, and again started with the second wave, and already again the talks are going on about the third wave. So like again, so that media also adding so many things, and of course social media, lot of messages, suggestions, and so many things are happening by so many people, and as a result of this many people are in confusion what is the right thing, how exactly like we should go ahead with planning for either treatment or like safeguard our the dear ones, even though like doctors even we have a lot of confusion as like students also like having a lot of confusion, like how to like safeguard their family members and themselves. So this in this during that period, so this batch FMMC batch 2018 brought out a very innovative idea. So I would like to congratulate the FMMC batch 2018 Prometheans, and in association with the Alumni Association of Muller Medical College, who has organized this innovative program, COVID Epignosis, Fight the Infodemic. And they have chosen a very good speakers, and of course that all from our the medical college, with a lot of information and much experience in dealing with this COVID cases since the last year. So definitely they're going to like share their experience and knowledge so that we can like take care of ourselves as well as our the family members, the friends, and all those things. And this officially I declare this the program open, and also I welcome and congratulate the organizers as well as the participants who have responded in a very large number. I think it is open for all the medical students of the FMMC. I heard that actually Aaron mentioned about more than 300 participants who are registered. So definitely this the program is going to give a lot of light to like many of you people a take-home message, and so that you can take safeguard of yourself as well as your dear ones. So on behalf of management, again I congratulate the organizers, and I wish all the best for this program, and I wish all the participants attend the entire that 4 programs which is organized by the organizers, and get a good message. Thank you very much. Dean may join somewhere in between, that he wants to see how the programs will be going on. So he may join later after some time.
Thank you, sir. Thank you for your kind words. I'd also once again like to extend a very warm welcome to all the students present here, to all the dignitaries, to the management, to the members of staff, to the heads of departments, without whom this event, this fight against the infodemic would have just been a concept and not an actual reality. So thank you all of you all present here today for making this possible. Before we start off, I'd like to share a story with all of y'all. Now, this story is of an award-winning photojournalist, Alesso Mamo. And Alesso Mamo documented the aftermath of the first wave of the pandemic in India. Alesso and his wife, they tested positive for the first time in September 2020 and were quarantined. They recovered fairly well and went back into completing their photojournal. Throughout their post-COVID journey, they were very reckless about very small things like the masks they wore or their hand hygiene. And evidently, Alesso and his wife fell sick. They contracted the virus the second time in April 2021. Alesso's wife sadly passed away a month later. They were under the misnomer that since they had tested positive the first time, and had been cured, they wouldn't contract the virus again. Although educated, although socially aware, misinformation sadly cost Alesso his wife. Now, this is not just a story of Alesso. This is a story of a multitude of people who have perished under the strongholds of fake news, rumors, and misinformation. What's baffling is these facts. In the last 90 days, around 4 million videos were uploaded on YouTube under the COVID-19 classification. About 20,000 articles have been published in the Google Scholar since the beginning of the pandemic. In the month of March alone, 32 million tweets included the terms coronavirus, COVID-19, the pandemic. A pandemic now is something most of us have never faced in our life before, and it grants us the constant urge to voice our opinions. Teachers, students, professionals, educated, uneducated alike. This overabundance of information is extremely taxing, especially when we are in need of accurate and reliable sources. So it is imperative to conjure a system to create social awareness amongst the general public to hasten the decimation of the pandemic, which is why today the batch of 2018, in association with the Father Muller Alumni, have decided to take up this battle against the infodemic. Without any further ado, I'd like to introduce today's speaker, Dr. Sudhir Prabhu. So Dr. Sudhir Prabhu is a professor at the Father Muller Medical College. He's a professor of community medicine. Dr. Sudhir Prabhu is an alumni of KMC Mangalore and JJMMC Davangere. Dr. Sudhir is a certified national TVAC trainer for the National Cold Chain and Vaccine Management Resource Centers, NIHFW and MOHFW. He is also a national effective vaccine management consultant for the NIHFW assessment in more than 10 states. He is a part of a 2-member team constituted by the State Health Commissioner and the Vice Chancellor of RGUHS for the investigation of COVID outbreak. Dr. Sudhir is a member of the COVID-19 Dakshin Kannada District Expert Committee. He's a member of the Dakshin Kannada District COVID Data Analysis Committee, and apart from that, he's also a member of the Dakshin Kannada District COVID Death Audit Committee. Dr. Sudhir is actively involved in treating COVID patients at the urban and rural setting, and he continues to inspire students, healthcare workers, by his talks on health awareness about COVID-19, about home isolation, about COVID vaccinations. And we're graced to have his presence here today. Dr. Sudhir, thank you for your presence here today. It's an honor to have you among us. Over to my friend Ryan, who will be speaking about a certain rules of procedure.
This is just a gentle reminder that this event would be a voluntary fundraiser as well. The donations received will aid to reach out and support the less fortunate patients of Father Muller Medical College Hospital. Your generosity is deeply appreciated. So as medical students, we're constantly asked questions by those around us, and many a time we are unable to answer them because our medical system is undergoing such an enormous change on the daily right now. So here's an opportunity to consult an expert on the field. So do pour out your questions and your queries in the chat box in the comment section. We will address as many as possible. So without further ado, Sudhir sir, the stage is yours.
Good evening. Am I audible?
Yes, sir.
Yes, sir. You are audible.
Can I share my screen?
Yes, sir.
It's visible, right? Okay. Good evening, everyone. As rightly told by Nagesh sir and as well as the organizers, the pandemic doesn't seem to end. Nor does the amount of misinformation which is pouring in the social media, and what we thought was something which would not haunt Indians as much as the Westerners is haunting us equally, if not worse, in terms of both morbidity and mortality. So it becomes very important as medical graduates, you need to understand what are the things which didn't go well, where are we right now, how's the situation. Also, the things relating to transmissibility or clinical management, the pathophysiology, it's every time it's like a new thing. It's like a mirage for us when we are there in the field, when we are seeing patients, when we are doing death audit of COVID cases. So I would like to share some important things. At the same time, I would like to tell you that as you are medical students and already we have seen from the last wave, I think you know the basic important things of infectious disease epidemiology. That is the reservoir, source, interrupting transmission, which went through mask, use of hand sanitizers, washing hands, maintaining social distancing. So I'll not be talking about that. So what I'll be talking or focusing mainly on is what are the new things, what as medical graduates you need to know. And at the same time, as rightly pointed out, the needs of the community now are increasing. They because we don't have enough manpower, we don't have enough healthcare professionals to address their queries. So obviously the questions will start coming to you. Okay, so you should be in a position to at least answer those queries relating to the disease, some pathophysiology, when to say that the condition or the clinical condition has worsened and when they need to refer. So these are important things. So with this background, I would like to start the presentation. It's actually takes less of a presentation. I would like to answer more queries. So let's try to keep the lecture to almost like 60 to 65 minutes, and then we can have more of a discussion if everyone is okay with that. So my contents are under the following headings. What is the public health importance of public health emergencies of international concern or pandemic? What do we call the epidemiological situation of COVID-19 right now? The epidemiological variants of SARS-CoV-2. Are they really the variants of concern or they are just scariants? So then we'll be talking about prevention and control, which is the heart of COVID-19 control, testing, tracing, and treating, the 3 T's, which used to be called earlier. Now a 4th T is very important, and you guys should know that, that is triaging. Okay. And next is home isolation. What are the key points and concerns? COVID-19 vaccines. I think it's a topic in itself, but let's see how much we can try to cover it. Take home messages and question answer session. I think I would wish this to be the taking the most important time of the particular talk. So what has happened? COVID-19 timelines. I'm sure everyone knows about this. It started in 2019 last month. actually the second week of December, when they started seeing a lot of clusters of pneumonia of unknown origin. And later on, it was isolated and found to be a new virus, a novel virus rather, of SARS gene itself. So they named it SARS-CoV-2 because SARS virus was earlier there in 2002. So that automatically became SARS-CoV-1, and this was SARS-CoV-2. There are confusion with the nomenclature. We'll discuss that slightly later. How names come and all. Then the disease was called COVID-19, which SARS-CoV-2 was causing. On 27 January, WHO had declared it as a public health emergency of international concern. So what's the term mean? What is a public health emergency? Meaning any disease which can be of a pandemic threat. Because the first thing what happens when the new disease is introduced, okay, I think we all know, we have learned in third year, how does a novel disease normally start? It's animal to animal, then animal to human, then sustained animal to human, human to human, and then it spreads all across the geographical variance. That's what is called the phase 6 of the pandemic. Okay, so that mainly because it can interrupt travel and trade. So people can't cross boundaries. They can't go from one country to another country. There is a concern. We had that last time in March. Okay, we were putting restrictions on people coming from China, Italy, France. Okay, so Mangalore particularly, the main issues were people coming from Middle East, because we have international airport and we also had so there was a double concern, mainly with international travelers. So that's why it is called a public health emergency of international concern. So it shouldn't interrupt. So that's why that we have international health regulations. Okay, 30th January, we saw the first case in India, in Kerala. And 11th March, okay, so there was a gap of almost 2 months, and WHO was criticized for this, if you remember, to declare it as a pandemic. Okay, and 12th March, India saw the first death in our own state, in Kalburgi. So looking at pandemics, so pandemics are nothing new. We have seen them, okay, but pandemic of this nature probably last was in 1918 with the H1N1 Spanish flu, which had caused a havoc and had similar waves or generations. So if you see the COVID-19 mortality, which is of major concern, it's about 3.5 million. Currently, it's 3.5 million. So how does an outbreak normally evolve in a country? Once it starts, so you need to remember there are 4 stages in which a pandemic normally enters into a country. The first phase, because the disease is totally novel and it would not be there in the country, it will be mainly from international travelers, okay, people who are coming from abroad. That is phase 1. So definitely, if you test them, you put them in quarantine, test them early. So here you need to differentiate the terms. Again, I saw the term quarantine and isolation being interchanged. So you need to remember quarantine is for a healthy person who is more likely to have a disease. We keep him in a separate place, not allow him to mix with other people for the longest incubation period. Okay, or twice the incubation period of the disease. That is what is quarantine. While isolation is for a person who is already having the disease. Okay. So idea of isolation is to ensure that he doesn't transmit to others. The idea of quarantine is to detect him as early as possible and to let him back into the community. Okay, so that is what was stage 1. Okay, mainly international travelers. Stage 2 is clusters. Okay, so invariably this international traveler who will be coming from abroad will be visiting his hometown or a local village. Okay, he'll mix with so many people. Okay. So obviously all those people who are mingled, it may be his family or at a workplace, okay, all those people who have come in contact with him, and because this is airborne, okay, so it spreads as a cluster. There will be a lot of cases and they will have a common thing. That's why it is called a cluster, that is meeting this person who has come from abroad. Okay, that is stage 2 or cluster transmission. If you remember last year, we had a lot of clusters, like although it is some clusters are wrongly labeled, but still we continue to remember it like that. Like the Tablighi one, the Nanjangud one. Even in Mangalore, we had our own super specialty hospital, First Neuro, which was supposed to be branded by the local people as the case of reason for spread of COVID in Mangalore. But anyways, a hospital will be having COVID cases. So calling these names will be very tricky. But the idea is the stage 2 is when you have clusters, a lot of cases having a common thing, a common epidemiological link, and that's where the transmission will be seen. Stage 3 is what is called as community transmission. Okay, so community transmission is when we don't or when we can't identify the source. So a person comes with symptoms, you test him, he's come positive, he didn't have a travel history, he's not gone outside his home, he has not met any international traveler, he was not part of any cluster. Okay, so when a lot of these cases start happening, okay, when we can't identify the source from where he has got the disease, that's what is called as community transmission. Okay, so most of the countries which are seeing peak of COVID are in community transmission of the disease. Okay, so India, although we deny, I'll come to that slightly later in the WHO presentations, but it looks like as we see normally in our field practice areas and when we go to the community, a lot of cases we can't identify the source from where they have got the disease. Okay, so it's very evident we are in community transmission, but still we are in denial mode that we are in stage 2 itself, we have not stage 3. And last is stage 4, which is epidemic, widespread. Okay, it may involve the entire village, it may involve the entire ward. Okay, that will create mayhem. Right, now, what are the health issues and concerns with public health emergencies? First is accessibility and availability of health services. I'll give you a classical example. Last year, March 24th, when Janta Curfew was introduced, the next first was on Sunday, the next Monday. Okay, so almost all the hospitals have stopped seeing fever cases. Okay, so there was some total chaos, and people had confusion even after that for accessing other essential healthcare services because of COVID. Because most of the hospital, even our district Venlock hospital, the moment it was declared a dedicated COVID hospital, okay, all other essential healthcare services in that hospital stopped. Okay, it's a district hospital which was catering not only to people of Dakshina Kannada, but neighboring districts, and also people used to come from Kerala also. Okay, so that is the major concern. The healthcare system is put on enormous pressure. Okay, that's how pandemics are. Okay, the resources are scanty. You don't have doctors, you don't have drugs, you don't have equipment to take care of the needy, you don't have beds to keep these patients. Okay, the care of the vulnerable groups, especially the elderly and children, becomes very difficult. Okay, the people with comorbidities, there is decreased healthcare utilization. People are scared. Okay, we used to see this. If at all we go to a medical college hospital or a tertiary care hospital, there will be COVID cases. So they'll just stay at home till the condition worsens. Okay, and then present very late, that to a primary healthcare center. Okay, so it was very bad. The scenario was very bad. There was a lot of fear. There was a lot of apprehension to seek healthcare. Pandemic preparedness and response. Yeah. So lockdowns, what was normally announced, that's the time taken for healthcare facility or health system to take time so that we are prepared to at least make up for the renewable resources. Okay, it may be beds, it may be HR, it may be oxygen. Okay. The regulations also have an issue. Lockdown were affecting migrants a lot. We have seen last year also and this year also. Regulations like compulsory wearing of masks. Okay, people can't go out for even essential goods, procuring essential goods. Okay, there was ban on over-the-counter selling of paracetamol tablets. Okay, so a lot of time, this was unique for Karnataka. Okay, that there are both pros and cons. Paracetamol not giving over-the-counter so that every fever case at least seeks care, but at the same time, people with other milder ailments were not able to procure it for other conditions. So it was a double-edged sword. Then clusters of COVID cases and deaths. So I was talking about this. This is the WHO dashboard. Okay, this is of May 26th. If you see, all the 5 countries badly hit. Okay, and all are in community transmission except India. Okay, that's what I wanted to mainly share in this chart. Now coming to the morbidity and mortality statistics, if you see, normally the second peak is always higher. That's what we had been seeing. Okay, But people are commenting on India's morbidity dipping down. The peak is almost down, but mortality is still remaining stagnant. Okay. The main reason for this being the deaths, what we are seeing now is almost of those people who had diagnosed COVID 14 days back. Okay. So this is one impression which you need to remember as medical students if someone asks you. Okay. So probably the curve also will start dipping after around June 3rd. Right. Now, why this put? The idea is, if you see, Brazil had just recovered from its second wave and already it's seeing a third wave. Okay, while India is seeing a dip in its second wave. Okay, Brazil, the number of cases now has outnumbered India's, but it's almost double. Okay, the number of cases are almost double of that of India. Right. So coming to the mortality. Okay, so sorry, one sec. Yeah, so mortality, the mortality rate is 2.91 per million population. Okay, it's about 2.91, which is far less as compared to Brazil. Okay, and also the reproductive rate, which talks about the infection, okay, or the transmissibility. So an R0 of 2 means one person is likely to infect 2 more people. Okay, and from that invariably we'll be able to calculate the secondary attack rate. Secondary attack rate is nothing but 1 minus 1 by R0. Okay, so if R0 is 2, secondary attack rate will be 50%. That is, if there are 4 people, 2 will be affected. 2 people who have not vaccinated or not come in contact, who have not developed COVID in the past, will develop the disease. So if you see the R0 of COVID from the first wave and second wave, the difference. Okay, so it was somewhere around 4. Okay, for India. And over a period of time, it has gradually evolved. And in the second wave, as compared to the first wave, what we saw, although the R0 was lesser, the incidence of close transmission, that is household transmission, was much more in the second wave. Okay, it was involving everyone in the family. So secondary attack rate seemed to be much higher, although this graph tends to show something else. But what we saw is something different with the second wave. So was this a new virus, or was it something related to the epidemiology of the disease per se, or the behavior of the people, is something interesting to learn. Right, now coming to the Indian scenario. Okay, if you see, the most affected states look to be in the southern region. Okay, so the bubble, if you see, okay, it's more in the southern states. If you involve the top 4 states, okay, Maharashtra, Karnataka, Kerala, and Tamil Nadu, they account for almost 50% of the total case share of country, the new cases of the country, and also the deaths. Okay, that's surprising. So I have kept it on purpose so that you start thinking in that term also. While the case fatality rate is somewhere around 1.15%. Okay. There are states like Kerala and Odisha which have case fatality rate of almost 0.3%, while there is Punjab which has a case fatality rate of 2.9%. So that is talking a lot about the health system of the country. Kerala, because of having a case fatality rate of 0.3, was said to consider not to be following the COVID death guidelines, which was given by WHO. We were not including all COVID deaths as a COVID death, because if there was any other associated incidental or a precipitated event. But the further slides, what I'm going to share, will show you what actually happened. Yeah, so this is one interesting thing what I wanted to share. That is, if you see the bubbles, it looks as if the Indian share is mainly by the southern states. Okay, so if we compare the graph, okay, look at Maharashtra, obviously the number of cases, total cases this is, okay, it's the peak, followed by Karnataka and Kerala are almost the same, second and third. Now look at the death rates, okay, Maharashtra, obviously because the numbers is more, Karnataka almost the same as the number of cases, at the worm looks the same, but look at Kerala, okay, it's almost flat. So is it because of a less number of deaths being reported as COVID? But this you have to see the discharge or the recovered cases. Okay, so the worm is a bit higher than Karnataka. Okay, so there is something going right in Kerala. So regarding the number of cases, the genuine information what we get is from the media bulletins. So Karnataka releases its media bulletin, Karnataka state, as well as it will be for every district. Okay, so even Dakshina Kannada releases its daily bulletin. Okay, you just have to go to the site dk.covid19.in. I'll share it with you slightly later. So you'll get to know all the details about what has happened, how many are in quarantine, how many discharged, how many deaths, how many active cases. Okay, everything on that website. Now, to know the true burden of the disease, okay, because we know that a lot of people are not coming out to test, okay, and to add on to the burden of the natural history of the disease, we know even in Bangalore, we have seen with the data, almost 50% of the cases are asymptomatic, even in confirmed positives. Okay, so a true burden can be estimated only by something called a seroprevalence studies. Okay, for this, there were 5 institutes which were identified. Okay, and till now, 3 sero surveys has happened. 3 sero surveys have happened from August 2020 to February 2021. The report of the 3rd sero survey was out, and this is very interesting. Okay, so this alarms, the seroprevalence thing alarms you that the major, almost all the age groups had somewhere around 1/4, almost 25% to 30%. There was antibody titer. Okay, but in rural areas, okay, it was very low. So this should be taken very seriously, because the next wave, if at all it is likely to happen, if it is in the rural area, it's better we should be prepared with adequate resources, because the seroprevalence studies show these people are not having antibody titers of sufficient amount as compared to the urban people, especially the people living in urban slums. Obviously, you can understand, because overcrowding, poor sanitation, so person-to-person transmission is higher. Similarly, urban non-slums also, the prevalence is more than 26%. Okay, but 7% dip in rural area. So this is this needs to be seen seriously by policymakers. Now, coming to the deadliest diseases, why are we so much concerned about COVID if it has a case fatality rate of somewhere around 1.15, global fatality of somewhere around 2%? Because there are much more worse diseases, rabies, encephalitis, H1N1, AES, encephalitis. Okay, the problem what COVID is causing is, so the resources, the crunch in resources what we are having. Okay, it may be doctors, it may be beds, it may be requirement of oxygens. Okay, we had a vast population, sudden increase in the number of cases. All these are not sudden increase. Okay, tuberculosis is causing deaths, but it's something we know the natural history, we know the treatment, and the additional concern is vulnerable groups are starting to have the disease manifestation. Not just that, the data also says the death rates in 0 to 10 is not declining as compared to the first wave. Okay, so this is concerning. Although if we look at the mortality data, still the maximum number of deaths we are seeing is in the elderly, that is above 6 years. But last time when we were doing death audit, a lot of people there were never cases who were like 30-year-old, 35-year-old, 40-year-old, but now we are seeing more often. So every week we are getting to see at least 5 to 6 cases in this age group, which is a concern. Okay, and another important thing is the long-term sequelae, which a lot of people don't know. Last year, when people have recovered and coming back with breathlessness, that's the time we also thought that there will be a long-term sequelae, because the COVID, the SARS-CoV-2 actually post-ARDS, okay, the lungs are very badly damaged. Okay, so that may have a long-term consequence. The patient may take somewhere around 6 weeks, at times 6 months, okay, for total recovery. So that's a very, very serious thing in terms of DALYs lost. The patient can be affected very badly for his activities of daily living. Especially imagine if he's the only productive worker of the family. Now about the virus and disease. Now the agent we have already discussed. It's called the SARS coronavirus 2. Some people also have started coining it human coronavirus 19. Okay, so don't get confused. Both mean the same because many people are not happy calling it SARS-CoV-2. Okay, they want to call it COVID-19 to give a separate identification from the SARS nomenclature. It causes COVID-19 disease. So WHO is not the deciding authority for this. Again, people keep saying why the names are confusing and all. So WHO is responsible only for naming the disease, okay, while the International Committee on Taxonomy of Viruses names the species. Okay, so that's the agency which has coined SARS-CoV-2. So it's a enveloped RNA belonging to beta coronavirus, suspected to be of zoonotic origin from the wet market in Wuhan, China. What does it do? So the entry of the virus is through the ACE2 receptor, and infection is mainly through an infective case. Okay, so as of now, the most important source being droplet infection, that is a direct route of transmission through close contact. Okay, so droplet infections. Surface infection, not totally impossible. There are chances, but lesser extent. And I think many of you must have read the Lancet paper, which said, and that had raised a lot of eyebrows, that COVID can be transmitted in the air. Okay, it is airborne through aerosols or what we call droplet nuclei. Okay, but yeah, it's very, very meager. The moment it is droplet nuclei, invariably, most of the preventive measures, what we are suggesting now, may seem ineffective. But no, what we are seeing with the best available data, most important route of transmission is droplet infection. So that's why the role of use of hand sanitizers, wearing masks, maintaining social distancing, keeping a distance of at least 2 meters from another person will continue to be very important. Now, coming to the pathophysiology, almost 80% of the cases are mild or asymptomatic. Okay, so they'll recover on their own like any other acute respiratory infection. Okay, a few of them, and almost 10% of the cases, will turn up as moderate COVID. Okay, they may require some oxygen support. The lung involvement is mainly because of an immunological response. So the immune reaction to be subsided, that is a patient who is having hypoxia, might be needed to be started on steroids. Okay, that's what is a moderate COVID. And the saturation drops. Severe COVID is when the saturation is even less. Okay, the person may have COVID pneumonia or any other lung pathologies, and critical when there is either ARDS, septic shock, okay, or any condition which could cause grave danger to the life of the patient. So these are the 4 important terminologies which you need to remember. Okay, mild and asymptomatic COVID, moderate COVID, severe COVID, and critical COVID. Okay, so these are the accepted terminologies globally. So rather than using too many terms and confusing categories and all, okay, so this is a standard term where you know what the patient has and how can he be managed, where he can be managed, and what all remedies or treatment can be given to manage these patients. Okay, right. So the main reason for pathophysiology or the condition, clinical condition worsening, is a state of hypercoagulability. There will be a cytokine storm. Okay, there will be COVID pneumonia, the filling ARDS, which obviously interferes with oxygenation, ventilation, perfusion, and leading to hypoxemia and sepsis. Okay, so this is very, very important. What has changed from the first wave to the second wave? Okay, so we saw a dip last time in somewhere around September, October. Okay, so a lot of people were thinking we are having a good immune response, we'll not have a second peak, but there are good amount of evidences to say that we were lax. The human behavior had a very, very important role. Okay, we let our guard down. So wearing of masks. We also used to see in our centers also that there used to be cases, although not as common as in August or what we are seeing last month. But people, moment you say COVID, they just used to laugh, thinking there is nothing like COVID. Okay, they may not have the disease. At the same time, there was a risky culture which was there in the youngsters. Okay, this was around the November, December time. They're like not wearing masks. There were a lot of parties. lot of get-togethers, lot of marriages. Obviously, we can't deny the role of religious gatherings and political rallies, which also might have contributed to it. But they were getting the infection promptly, and this is supposed to be one of the hypotheses that the young adults who were working and who were having a large number of social gatherings tend to have a large number of viral load, and probably that's why they were having much severe COVID disease in the second wave. But all these are hypotheses. But the risk, what was happening was they used to get this virus promptly from the community back to home, where there were vulnerable adults. Okay, so that was a very important concern. Apart from this, we can't neglect the role of the virus per se. What can the virus might have caused in the form of mutation or variants? Yeah, now the first wave and second wave, what has actually changed? So if you see the first wave now actually looks like almost a flattened curve, because the second wave was a sharp peak and a sharp fall. That's normally how an infectious disease, the epidemic curve will be. Okay, so this is what we call waves, what normal people normally say waves. In infectious disease epidemiology, we also say generation, waves or generation. Okay, so the sharper the rise, the sharper will be the fall. That's what we are seeing in the current, the second wave. So now coming to the variants, what are the issues and concerns? The variants are basically, it's an inherited property of the virus. So remember, when it's an RNA virus, they are highly unstable. Okay, they'll keep on mutating. Normally, most of the mutations will be causing them to be more less pathogenic. But sometimes the mutations may be of such nature that they may start causing more health issues and concerns epidemiologically. So that's why we need to have a constant look through epidemiological surveillance, clinical surveillance, whether it's variants which are causing the problem or not. So what these variants can cause, they can increase the transmissibility, infection rates can increase. Like I was telling you, last wave we didn't see a lot of people in the household getting the disease, but in the second wave, we are seeing more that. There is more morbidity, there is more mortality, ability to evade detection by diagnostic tests, by RT-PCR. So if you see the RT-PCR nucleic acid amplification, it's not just for one gene. Okay, they do it for multiple genes, so that even if there is mutation in one, it can be picked up in the other genes. So decreased susceptibility to the currently used antiviral drugs or to the monoclonal antibodies. Okay, so if you see now the new monoclonal antibody cocktail, casirivimab, which is being brought in, and it was their viral monoclonal antibodies were there in the NIH treatment protocol, but already they are saying the E484Q mutation, which is seen with B1.617, is doubtful in terms of susceptibility viral monoclonal antibodies. So that's a concern. That's why the variant will have an antiviral concern. So ability to evade the natural immunity, ability to infect the vaccinated individuals, okay, otherwise who would be protected with the previous, if only the previous strain was there, or increase risk of certain conditions like long COVID. Okay, we'll talk about long COVID, or a multi-system inflammatory syndrome, also called MISC. This is mainly seen in children, or a change in affinity to a particular demographic or clinical group. Okay, that is it starts to affect children, like what is supposed to be the variant which is affecting right now in Singapore, and also immunocompromised individuals. Now, how do we identify the variants? Now, this is very, very important. So there is three things what we need to know about variants. There are something called variants of interest or variants under investigation. Then there is variants of concern, okay, and there is variants of high consequence. So variants of interest are predicted to affect transmission, diagnostics, therapeutics, or immunostate. Okay, like our B1.617.1 virus. Okay, so variant of concern is when the transmissibility and severity and also it has a severe impact on the current ongoing diagnostic treatment and vaccines. Okay, like the B1.1.7, what people normally call the UK strain, or the Indian B1.617.2, which people call the Indian variant. So now we were okay till the terms Wuhan virus, China virus, UK virus, South Africa variant, Brazilian variant were used, but moment the Indian variant term came, there was a lot of opposition on social media. So it's stigmatizing. It will have a lot of political and economical impacts. It's not good for a country. Okay, already we have seen a few diseases named, so like the Zika and Ebola. Okay, the Uganda and Congo, they have been stigmatized using these names. Okay, so it's agreed that viruses shouldn't be tagged on to a region. Okay, so we need to identify them with a particular lineage or a particular mutation. Now there is a confusion. How do we call them or how do we name them? Okay, that's why people tend to use the easier way around. Okay, but as medical students, I expect you not to use those words. Okay, not call UK variant or a Wuhan virus or an Indian variant. Okay, so you need to understand what is that variant, what is the classification of the variant. If you understand that, at least you can probably convey and start using the right term. Okay, I do understand it's slightly complicated remembering it, but at least if you understand how they are named, that makes job much easier. Now the last one, luckily we have not seen any variants till now to be a variant of high consequence. Okay, that is the existing treatment or the medical countermeasures, including prevention. Okay, if they are not effective, that's called variant of high consequence. Or if there is a high vaccine breakthrough infections. What is this vaccine breakthrough infections? Okay, people who have taken the vaccine after taking the second dose of the vaccine after 14 days. Okay, even after 14 days, more than 14 days, if they start developing infection. Okay, that is what is called a vaccine breakthrough infection. So if there are a lot of high vaccine breakthrough infections, that may be one of the causes can be a variant of high consequence. So we need a lot of genomic surveillance, genomic testing. Okay, right now it's very small. We have just 10 labs. Okay, so we need to see, especially with high viral loads, where the CT threshold, cycle threshold value is less than 20, 15. You need to catch those conditions and see whether there is which variant is circulating. So how these names are given, currently there are three classifications, three taxonomical classifications. I'll just go quickly. One is called the GIS aid. The second one is the Pango lineage, which I was telling you right now. Okay, the Pango lineage, there are the main lineages are A, B, B.1, B.1.1, and so on and so forth. So the two, what I was telling you, the one which is called the Indian variant, B.1.617.2. Okay, it belongs to B.1 lineage. Okay, so it's basically like, imagine B.1 is the grandfather. Okay, and B.1.617 is the 617th virus found in that particular lineage. Okay, so that's what is B.1.617 mean. Similarly, the UK variant, which is B.1.1.7. Okay, so in that also, the B.1.1 is the major lineage. Okay, from there, it's the 7th virus which has been isolated. Okay, that's how the lineages are named. Okay, so GIS aid gives a different nomenclature, and next strain classification uses the year when it was isolated. Okay, and the name of the current strain. So, for example, the zero virus, what we call the zero Wuhan, what was isolated in Wuhan was 19A and 19B. Okay, as per the next strain or the covariant assay. Okay, so after that, now we are seeing so many. So 20 is mainly talking about 2020, and now we are seeing the 2021. Okay, so it's there from A to I. Okay, so that's how the nomenclature goes on. Okay, so the phylogenetics, what all we have right now, if you see, most of the places, okay, it's not the B.1.617. Okay, it's others. Okay, mainly A, B.1.253. All other variants are there. Okay, so we have mainly others rather than the variant of concern. Okay, so B.1.617.2 is the only variant of concern, while 617.1 and 617.3 is still a variant under investigation. Now, what is the epidemiological definition? The WHO has given a surveillance definition: a suspect case, anyone who's coming with fever and cough, okay, or any three symptoms out of the following: fever, cough, fatigue, headache, myalgia, coryza, diarrhea, altered mental status, okay, And epidemiologically, if he's coming from a high-risk zone or has been come in close contact with a person who is in community transmission in the last 14 days, or if he's working in a healthcare setting, especially doctors, okay, so they will be suspect case. Or any patient coming with SARI, this sudden onset of breathlessness, saturation is below 94. And probable case is along with the clinical criteria of a suspect case. Okay, there is chest imaging is suggestive of COVID-19 disease. Okay, it may be based on CORADs or X-ray scoring, or if a patient is having anosmia or ageusia, loss of smell and loss of taste. Okay, so these are more likely pointing towards COVID per se. Okay, and confirmed is anyone who's diagnosed. Okay, laboratory confirmed. Okay, either with nucleic acid amplification or a rapid diagnostic test. Okay, so suspect, probable, and confirmed. This is the epidemiological definition. Now, based on clusters, there are 6 clusters I identified. Okay, flu-like without fever, flu-like with fever. Flu-like is mainly influenza-like illness. Okay, so then pure gastrointestinal. Okay, without having any respiratory symptom. Then there is severe one presenting mainly as fatigue. There may be other symptoms, okay, which may be related to respiratory or GI, but fatigue is a very important symptom. These are the patients who may worsen, so you need to be careful. Severe level 2, which presents with confusion. Okay, so last severe level 3 presenting with a combination of GI and respiratory. So see, these are the 6 clusters in which patients are coming to health facilities. Okay, so what are the presenting features? So most important thing, what you need to remember to differentiate between the 3 important classifications what we are doing in our country. The asymptomatic and mild is considered 1 or as category A, moderate is called category B, and severe is called category C. Okay, so most important thing are the vitals. Okay, if saturation is more than 95 or 94, okay, he is clinically stable. That's why it's green. Moment it starts falling below 94, but it is above 90. Okay, such cases are called moderate. Now, there is one important thing which you need to remember. Moderate cases, there is a term called happy hypoxia, which may be seen with younger individuals. Although it has been seen with adults also, but more common with younger individuals. That is, they start manifesting with breathlessness. Okay, only when the saturation falls drastically low. So you may not be able to pick them early because the manifestation is not there. Okay, so what do we need to do? We need to do a unmasking of this hypoxemia, doing something called a 6-minute walk test. That is, you ask them to walk briskly, okay, for 6 minutes with their pulse oximeter in their hand, okay, and then see whether there is a dip. Okay, if saturation was normal, but now after the 6-minute walk, if there is a dip, that is an indicator of happy hypoxemia. So such patients also will come under moderate COVID. Okay, last is severe when the saturation is less than 90. So apart from this, okay, you also have to look at other important vital signs. That is respiratory rate. Okay, if it is more than 24, but within 30, and if it is more than 30, it will be severe. Okay, similarly, heart rate, if it is more than 100, okay, it is tachycardia. So basically, hypoxemia, you know, it can manifest in 3 forms. Saturation will go down. There will be tachycardia, that is fast pulse rate more than 100, and there will be tachypnea, that is fast respiratory rate. Okay, and obviously it will it will affect all the major organs. Okay, so symptoms may be seen accordingly. Okay, so for example, if it is involving the CNS, the patient may not be able to comprehend well. He may be confused. Okay, he may not be able to complete sentences. Okay, it may start affecting the heart. It may start affecting the kidneys. There may be acute kidney injury. Okay, so these are all the manifestations of hypoxemia. So coming to the natural history, you need to understand the incubation period is roughly on an average 5 days. And from there are 2 important phases of the disease. First is the viremic phase, which is from day 0 to roughly day 5 to 7. And then onwards starts the inflammatory phase. So why this is important is you need to understand during the viremic phase of the disease, we don't want to start any patient on steroids. Okay, it can cause more viral replication and can be hazardous. So when there is a role of steroids, it's mainly in the inflammatory phase and only if the patient is having hypoxia. Okay, if there is no hypoxia, there is no role of steroids. But steroids are essential. They are proved to be life-saving drugs, but if used non-judiciously, they can be very harmful, especially patients who are diabetic and plus who are immunocompromised. And now we are seeing a lot of mucor cases. That's why. So if the conditions are like most of the 80% of the cases, what do we see? Asymptomatic and mild, they will recover by day 10. Okay, so day 9 is the time when the patient is supposed to be non-infective. Okay, so there is no repeat testing indicated. I'm again stressing on this, no repeat testing needed, because the virus may persist for approximately 3 months. I have seen a case we had seen in we had one lady who came to Jaipur. Okay, she was diagnosed in March, had fever for 3 days. 3rd day she came, tested positive, 17 days isolation. Okay, then recovered. 4 days later, she again started fever and cough, went to a private practitioner. He again ordered RT-PCR. Okay, it came positive. Again, 17 days loss of pay. Then again, after 4 days, she came to our Jaipur center, same fever. Okay, so the only thing I told her is, I'm not going to do a repeat RT-PCR on you. Okay, so this is very, very important. Otherwise, the patient probably for the next 90 days will be branded COVID positive. Okay, so you have to be very careful. No need of repeat testing. Okay, so one important thing, on 10th day, the patient can be discharged from home isolation. So the 10th day is either from the day of onset of the first symptom, or in asymptomatic case, from the day of testing. Okay, and the 10 days is valid provided the last 3 days, that is from day 7 onwards, the patient shouldn't have fever. Okay, and after day 10, the patient will have either recovery, or there may be in patients who had a bad lung involvement, there may be something called long COVID. Okay, so key important days, what you need to remember is day 5 first. Okay, any patient who's having persistent fever, okay, on day 5 along with cough, or a patient who is having a relapsing fever, that is patient had fever for the first 48 to 72 hours, he was asymptomatic, and on the 5th day again there is a fever spike. So that is an evidence that it can be a pneumonia. It can be either a viral pneumonia, primary pneumonia, or a secondary bacterial pneumonia. So you have to be very alert. Okay, day 7 is our average time, which we are seeing even now when we are doing death audit. We are seeing a lot of patients who are coming that there is a delayed presentation. Okay, so that's why we are not able to act very fast. So if this period can be reduced, okay, definitely good care if it is given in the first 7 days, patient will not worsen. But because of the fear, because of the infodemic, what we are rightly trying to tackle through this sessions, okay, if we can reach out to more of the people, okay, they can come early when the symptoms are seen early, and then probably we can take good clinical management of the drug. But when they start coming after this, day 8 is the time when there is already ARDS set in. Okay, that's the time when the alveoli are filled with fluid, the ventilation perfusion will be affected, and then it will become very difficult. Okay, you need to give high flow nasal oxygen. You may not need to, if the patient goes into respiratory distress, or if the patient goes into respiratory failure, you may have to intubate and start on mechanical ventilation. Okay, so that's why it is very, very important. Right, now coming to the testing and diagnosis, there are two important standard tests for picking up COVID per se. One is called the nucleic acid amplification test. Either it can be RT-PCR, CBNAT, TrueNAT, whatever it is. It amplifies the gene. That's what it is. And it is the current gold standard test, preferred test. Okay, it has a good amount of sensitivity, so it is gold standard. Now, when the cases are very high, and especially in difficult areas, okay, and rural areas, hilly areas, and a lot of patients are there, like in sustained community transmission, when there is a lot of cases which are seeing, want results very fast, that's the time we use rapid antigen test. Okay, so these are not sensitive tests, they are specific. That is, they have to be used only in patients who are symptomatic, COVID symptomatic. Okay, and if with COVID symptoms, the RDT comes positive, it is confirmed COVID, no need to repeat RT-PCR. But if the patient is symptomatic, okay, and RDT doesn't pick it up, you have to ask the patient to repeat an RT-PCR. Okay, because there is a high chances of RDT coming false negative because of its poor sensitivity. Okay, so you don't want to miss these patients. So RDT. Now, RDT is a very important revolution, and you have to acknowledge the WHO ACT tools, which have released a lot of rapid antigen tests, including ICMR. Okay, the first rapid antigen test, which I personally knew, was for HIV, rapid diagnostic test. Okay, so it took almost 5 to 6 years for rapid antigen test for HIV to come. Okay, for COVID, it came in a matter of 7 months. Okay, that's a commendable job. Now, antibody-based tests or serology, a lot of people are doing this, okay, but there is no role. You need to remember ELISA for antibodies. People are coming with value more than one, saying protective after COVID antibodies. Okay, there is nothing like that. Okay, even if you have to do specific for anti-spike protein. Okay, and it has to be more than 15. Again, it gives more patients a false sense of belief that I'll not get the infections. Okay, so for the time being, antibody tests are not recommended. Okay, so don't give any false assurance. Remember with antibody tests. Okay, so this is how the coronavirus SARS-CoV-2 looks like. Okay, these are the spikes. Okay, in antigen, we mainly try to pick up the nucleocapsid protein, and based on RT-PCR, we try to put the S, ORF, and multiple genes. Right, why do we need to do diagnosis? Yeah, some important things in the community level, we need diagnosis mainly for early detection so that we can contain the spread by good amount of contact tracing. Okay, so who all the people have, the patient has come in contact with, and start testing them and limit the spread of the disease. Third important thing is geographical spread. We need to know the variants of concern with good amount of genomic surveillance, and to have good surveillance, like active surveillance. If you remember, we used to come to the hostel and randomly and ask for a pooled sample testing. Okay, that is what is surveillance. At an individual level, right now, at an individual level, we need to know how much is the viral load. Okay, so in the RT-PCR report, there is something called a CT. So a lot of people get confused with the CT of RT-PCR, corads of CT scan, and the CT score. Okay, so you need to first differentiate this. So CT in RT-PCR talks mainly about the cycle threshold, or it indirectly tells about the viral load. Okay, so cycle threshold or CT value less than 24 indicates the patient to be having high viral load. But again, don't scare the patient, or don't be scared looking at the CT value, okay? Because it depends on a lot of factors. Okay, when was the sample taken? Whether it was 5 or 7 days. Obviously, the viral multiplication would have been more, and how the procedure was done, who had done it. Okay, so a lot of factors will decide the CT value. So not to be bogged down by the viral load or the CT value of RT-PCR. The second one is to know lung involvement. Earlier, CT scan was rampantly used. Now, CT scan, there is radiological imaging. There has been ministry, DGHS, MOHFW have given a clear-cut guideline when a CT scan is supposed to be done. It's not supposed to be used for diagnosing COVID. Absolutely no. Okay, the only thing what you can show is it's an imaging test which can say whether there is lung involvement or not. And again, it's not very specific. Okay, so the things have changed now. Things have evolved. So a CT scan, there is something called a CORAD score. CORADs. Okay, so CORADs 4 and above is a high level of suspicion of COVID. So there are some radiological features like ground glass opacities, which are more peripheral and which are towards the lower lobe. So that's what is very typical of COVID. Okay, so CORADs 4 is and more is high level of suspicion. So when CORADs plus there is RT-PCR positive report, it automatically becomes something called CORAD 6. Okay, that's the highest level which can be attained in CORADs. Now, to predict prognosis, the patient they were using CT scan score, CT score. Okay, that will say it will divide the lung upper lobe, middle lobe, lower lobe, and right and left. Okay, and see how much of the lung is involved. Okay, each lobe. Okay, 25%, 50%, more than 75%. So any CT score more than 15, the maximum CT score which can be reached is 25. Okay, so any CT score more than 15 is considered to be severe COVID, and somewhere between 9 to 14 is called moderate COVID. Okay, so lung involvement is present. That's what CT score used to suggest. And for management, okay, we used to do inflammatory markers. So what are the inflammatory markers commonly used? You can remember with the mnemonic C, D, E, F, G, H, I. Okay, C is CRP, it's an inflammatory marker. D is D-dimer. Okay, it's a fibrin degradation product, so it mainly indicates hypercoagulability, basically to start an anticoagulant. Okay, E is ESR. F is ferritin, again an inflammatory marker. Okay, then I, interleukin 6, which talks about the cytokine storm. Okay, where you can use where people used to use tocilizumab rather. Okay, so that was the main inflammatory markers. Okay, the vaccine response, with if at all, if people have to do, it's the anti-spike protein I've told you, and it should be more than 15, but not to be routinely recommended. It can give a false sense of security. So how does the testing happen? Okay, so moment you go to a collection center. So these are the ICMR empaneled laboratories. All medical college hospital plus district West Benlock hospital are ICMR approved. So they should be there, and they can do the RT-PCR test. So other places like our PHCs and all are collection centers. So if you come to our PHCs, they'll be giving you 2 swabs, one for oropharyngeal, one for nasopharyngeal, and a container which is having this fluid. And moment you are tested, you will get an SRFID. So having your mobile with you is very, very important, because unless your SRFID comes on your mobile phone, you will never get to know your test results. Okay, there have been cases where SRFIDs have not come and patients have come back and asking what happened to my test results and all. And this is more so important, especially in Bangalore regions where BU number is through the SRFIDs. In Bangalore also, in other places also, we give something called a P number, but that's not required for hospital admissions, unlike in it was in Bangalore earlier. Okay, so BU number very, very important. So once you get that SRFID, you can go to covidwar.karnataka.gov.in. Okay, and just type this 13-digit SRFID with the captcha. You'll get to know what is the status of the patient. Okay. Right. So why this particular picture looked at the number of tests being done. Okay. India is currently doing 1.46 per 1,000 people. Okay. And on that number, we are seeing our test positivity rate now is somewhere around 9%. Okay. So compared to UK, US, where it's around 14 per 1,000 population, and India's peak was almost 22% test positivity rate. That is, out of 100 tests you do, 22 tests used to come positive. In Bangalore, it was almost 33. Out of the 100 tests, 33 used to come positive. Okay, so this is the record now. We are still continuing to be in the high transmission zone, more than test positivity, more than 30%. And this is the state COVID. This is how many tests we have done till now. Okay, just look at the number. I think it is around 2.91 million done. Okay, 2.91 million tests. Okay, I hope I'm right. Sorry, 29 million. Sorry, 29 million tests have been done, including RAT and RT-PCR in Karnataka. Okay, till May 26 from last year. Now, what is tracing? Tracing is contacts, tracing of the contacts. Okay, it's an important thing in the control of the disease. And again, it goes by the phase of the pandemic. That is, in obviously say phase 1 and 2, obviously it has a high role. Phase 3, if there is community transmission, if we are not able to trace what is the source, it becomes very, very minimal. And I told you, we already have reached, although there is a denial phase. So the contact tracing should be limited at this particular phase. We should be trying to focus mainly on areas like hospitals or workplaces, where contact tracing might be useful. Otherwise, it is just an additional burden to the healthcare system. And what do we do in contact tracing? We try to categorize the contacts based on 4 important things. Okay, whether how long was the exposure with a confirmed case. Okay, and we saw the period of infectivity for the virus is 2 days before the onset of symptoms to almost 8 days, 7 to 8 days. But we consider it as 14 days. Okay, from after the onset of symptoms. So 2 days before to 14 days after the symptom, if a patient has whoever he has come in contact with, if it is more than 15 minutes without a mask and less than 1 meter, okay, so all these will be considered high risk. Okay, so if all the criteria are satisfied, even though he has not he has come in contact, but he was wearing a mask in 95 or a 3-ply surgical mask with a double layered mask, okay, that will become a no risk classification. Now, what will happen to contacts? Contacts will be put in quarantine, okay, for a period of 7 days for healthcare workers, and for general population now, because mainly suspicion of variants, for a period of 14 days. And they will be tested twice. That is on day 0 and day 7. Okay, day 0 is, imagine from the time when the close contact or the patient who has come with the disease. So for example, now I have confirmed with COVID now. Today my results have come. Okay, and my hostel roommate, okay, he will be tested immediately. That is day 0. Okay, and if at all it is negative, okay, and if he continues to remain asymptomatic, on day 7 again we'll test. But the quarantine period, because it's 14 days, we say anytime between day 0 to day 14, if he develops the symptom, he has to again go for a testing. Okay, so that is very, very important. So day 0 and day 7, testing if asymptomatic, and if symptomatic, any point during the 14 days period. Okay. Right, now triaging is very, very important. I told you treating was there earlier. Now triaging is equally important because we want to categorize these patients as whether they can be fit for what sort of a facility. Either they can go in for home isolation. Okay, so who are the people who can go in for home isolation? We'll see later. So those will be category A. Then category B are moderate, who will have to go to either a COVID they have to go to a designated COVID health center. Category A patients, that is mild cases, who are not satisfying home isolation criteria, will go to COVID care centers. Okay, designated COVID health centers will have oxygen. So these are the moderate cases who have hypoxia. Dedicated COVID hospitals are the tertiary care centers. Okay, now one important ruling which has come in the clinical management protocol is this is very important. Having a COVID result. Earlier, having COVID result was mandatory. I was telling you BU number, SRFID and all. Now it is not needed. Okay, so you have to give a standard of care and admission to DCHC or DHC depending on the patient's clinical condition also. So how does a monitoring of the COVID positive patient go? Say, for example, if I'm the doctor and the patient has come to my clinic, okay, I will be notifying about the ILI SARI case in the KPMEA website, that is Karnataka Private Medical Establishment Act. So we'll refer him for testing. He'll get his SRFID. Once it comes positive, his P number will come to the PHC. Okay, and that P number will be given to the hospital, and it also goes to the war room. Okay, Bangalore war room is in the Bangalore City Corporation. Okay, there will be 3 apps, Bhumi, Parihar, S3, that will be doing contact tracing, and the entire natural history from the day of symptom till he is discharged will be captured in this S3 app. Okay, an additional thing which has been done exclusively is along with the Suvarna Arogya Suraksha is the CHIMS app, CHIMS. Okay, so this is mainly health information, mainly to see for COVID, how many beds are available, how many ventilated beds are available, so it can be tracked real time. So now this is the new guideline which has come, okay, because the guidelines keep changing. Okay, this was 2 days back, the new guideline. So the treatment protocol is totally revised. So earlier there used to be ivermectin, doxycycline, now it's nothing. So asymptomatic, it's like any standard viral infections. Okay, you talk about COVID appropriate behavior, infection precautions, and plus 3 important things for viral infections. Okay, that is bed rest, plenty of fluids, okay, and antipyretics. Okay, so antipyretics will come mainly for mild cases, antipyretics, antitussives, and patients with cough in mild, they have told meter dose inhaler of budesonide. Okay, so each puff of budesonide, okay, will have about 200 microgram. So total of 4 puffs in the morning and 4 puffs at night. Okay, so that will make 800 microgram of budesonide for 5 days. Moderate and severe, I'll not discuss. I think Dr. Veena will be discussing it tomorrow. Okay, so basically the thing remains the same. So asymptomatic, only COVID appropriate behavior, infection prevention, and mild cases, budesonide, and if at all oxygen support required. And now the thing is very clear: if oxygen support is required, it should be in a hospital. Okay, it should be in a hospital setting. Similarly, that for steroid. So who are the patients who can go in for home isolation? So a person who is detected fit by a medical officer that he can be going in for home isolation. So who are these patients who do not have a comorbidities or who have comorbidities which is well controlled? Okay, no evidence of a severe COVID on testing. Okay, there is a caregiver available to take care of the patient 24/7. He should have a separate room for isolation with a separate toilet facilities, and he should have all the equipments, that is having a pulse oximeter, thermometer, okay, and number of a healthcare facility, a doctor with whom he can contact. Okay, so all these people will be declared fit for home isolation, and the patient has to sign a declaration form saying that I will be willing to go for home isolation. Okay, so what important things to be needed to be done when the person is in home isolation? These are the queries which normally keep coming. Okay, they can wear, they are expected to wear 3-ply mask throughout. Okay, a person who's taking care of that patient can wear an N95 mask. Otherwise, normally you ask the general population to limit the use of these N95 masks. Okay, they can follow double masking with a surgical mask and a cloth mask. And all the surface items like the utensils or the fomites, everything should not be shared. It should be specifically kept for him, and only one caregiver should be taking care of that. And immediately after handling those, he has to wash his hand with soap and water. Okay, that is very, very important. Okay, and if at all some article is soiled, you have to tell these patients, say for example, if he has coughed or vomited on bed sheet, okay, and now you have to wash it. You have to ask the patient, ask the caregiver not to mix it, okay, or because the chances of aerosols being created will be more. Okay, so you should not manipulate with these fomites as much as possible. And all the mask which is generated, okay, ideally you tell them if it is burnt, it's best. Okay, cut the thread of these masks and burn it. Okay, you can also, with the scissors, to prevent it being utilized, you can also ask them to cut it. Okay, they have to be segregated separately, ideally yellow mask, if they are disposed of in a yellow bin, because it's it shouldn't go with the solid waste in the municipal corporation. So this is very, very important. Now we also get calls regarding because Mangalore, there's predominantly flat cultures. Okay, what happens to a COVID positive's kitchen waste? Okay, can it be going to the municipal corporation? Yes, it can go. Okay, so these are the common queries which will be coming. So you should be in a position to answer this. Right. Okay. So yeah. So monitoring a pulse oximeter, temperature, okay, vitals should be done at least 4 times in a day. And to do this, he should maintain a chart box. You can also give this. I'll show you what can be done. And if at all, if at any point in home isolation, if he develops difficulty in breathing, if there is a saturation drop of less than 94, okay, if there is chest pain, breathlessness, or if you think he's confused, inability to complete sentences, all these are warning signs of hypoxemia. Okay, he needs to be urgently referred to a hospital and started on oxygen. So what materials are required? Some people may ask you, so if at all, if I have to be ready for home isolation, what are the things is required? So the home isolation kit should have at least 1 pulse oximeter, few lozenges, okay, coughlette or strepsils, whatever it is, okay, for sore throat. 1 bottle of liquid soap or hand sanitizer, 1 digital thermometer, at least 10 or more surgical masks, a notebook to write down all the daily monitoring details, and 20 tablets of paracetamol. So apart from this, having steroids, antibiotics and all will be dangerous. Okay, so a home isolation kit shouldn't have anything more than this. Okay. Similarly, for family members, you have to tell them, keep the contacts ready, keep resources ready, especially groceries. Okay, and keep good ventilation. This is very, very important. Okay, and keep a good diet. So balanced diet, good amount of water. Okay, and keep talking to them, at least if not through direct contact. Okay, so mental health thing is also very, very important. Okay, they shouldn't feel secluded when they are in the period of home isolation. Right, so they should also know where to seek help. Okay, the national helpline is 1075. In Dakshina Kannada, it is 1077. Okay, so any queries related to COVID ambulance or hospitalization. The eSanjeevani portal is also there. This is teleconsultation. For slightly elderly patients, you can ask them to go for self-proning. Okay, the proning protocol, I think everyone knows about this. Okay, so this is nothing but rather than sleeping supine, which puts additional pressure on the lungs, the liver will be pushing on the lungs. Okay, and to ensure good oxygenation basically to the entire part of the lungs. Now you ask them to sleep on their belly. Okay, you need simple things, 4 to 5 pillows. Okay, ask them to keep 1 on the head and keep the neck to one side. Okay, 1 below near the waist. Okay, just slightly below the tummy. It shouldn't compress on the tummy, the pillow. Okay, 1 near the ankle. Okay, and 2 near the elbow. Okay, so keep in this position for 30 minutes, 20 to 30 minutes. It becomes very difficult. Okay, in the initial period, because people are not used to sleep like this normally. Okay, so you can ask them to watch something, or you can talk to them so that they can get used to this. Okay, so once they are used to it, it becomes very comfortable. Okay, so after that 20 to 30 minutes, ask them to change to another side. Okay, right lateral. Then you can ask them to sit in the recumbent sitting up position for another 20 minutes. Then left lateral side, and then back to normal. So over a 2-hour period, you will be repeating this. Okay. So it shouldn't be done soon after meals. It should be avoided in pregnant ladies, and so otherwise, proning is a very effective tool. It has proven to be effective for improving oxygenation for patients who are in home isolation. Now, oxygen concentrators are not recommended. I'm sure there will be a separate session on this, but someone has said in home isolation, a lot of questions keep coming. We also used to get a lot of questions on oxygen concentrators and cylinders. So at least some basic things what you need to remember. This is a simple, I think you can identify that in the picture. So most important thing for an oxygen concentrator is you need not refill like an oxygen cylinder. Okay, so it will be taking out from the atmosphere itself. It should be able to give a continuous flow of oxygen at least more than 90%. Okay, the cylinder gives roughly around 97%. The industrial oxygen cylinders give around somewhere around 94 to 95%. The oxygen concentrators give somewhere around 90%. Okay, so the continuous flow should be at the rate not less than 5 liters per minute, because you need to see this. Okay, whether it is a continuous flow or a pulse flow oxygen concentrators. You need continuous flow oxygen concentrators of at least 5 liters. No point in taking 1 or 2 liter oxygen concentrators, and you need to monitor them thoroughly. And very important, tell the patients if they are on face mask and this thing not to give extra oxygen. Okay, that also extra oxygen is also harmful. And direct oxygen is also very harmful. So you have to have a humidifier. That bottle needs to be filled with clean water, preferably distilled water, not tap water. Okay, so that is very, very important. And try to wean as much as possible. Okay, if you can maintain in room air, that would be the best. Okay, so not more than 8 hours at a time if at home. Okay, and preferably, as I told you, now the current recommendation is oxygen should be given at the hospital itself. Okay, and if any oxygen concentrator is citing that it is mainly for home-based care, okay, it is misleading. So there is no oxygen concentrator, this was just a makeshift, especially in Delhi, Bangalore, where people were going into hypoxia and dying very fast because of non-availability of beds. That was the makeshift arrangement for the use of oxygen concentrators. Luckily, that's what we will not be seeing such kind of a scenario again. Right, breathing exercises, again, very important. Okay, so simple breathing exercises, and also even from recovery also, when we are telling them, it should be based on what is feasible and based on the lung condition. So how to monitor? I think pulse oximeter, everyone knows it. Okay, keep it on the either the middle finger or the index finger. Warm the hands. Okay, there shouldn't be any nail pains or so. This mainly sees the color. Okay, oxygenated blood and deoxygenated blood at each pulse. Okay, then it sends it back. Okay, let it settle for some time. Okay, the reading will normally keep fluctuating. So once it is constant, take the highest reading. That will be talking about the pulse oximetry reading. Okay, in conditions like hypothermia, hypovolemia, or use of vasoconstrictors and all, when it's suspected, okay, prefer to use other sites like ear lobe and all. That's preferable to monitor the saturation. Very important, vitamin mineral supplements, especially vitamin C, D, zinc, okay, are all, they are not cure for COVID. Okay, they may boost the immunity response, but it should be done before the COVID. That's important. This is the monitoring sheet, what I was talking about, what the patient has to maintain for 4 times. Okay. The 6-minute walk test, I've already told you. Long COVID symptoms, okay, persisting symptoms for almost 3 to 12 weeks also, beyond 12 weeks also has been seen. Okay, short COVID is something which recovers within 3 weeks. And if it is persisting between 3 to 12 weeks, it's called the post-acute COVID. And if it's persisting beyond 12 weeks, okay, anything, it may be related to neurological, respiratory, okay, that is called as chronic COVID. So all these are the symptoms, okay, mainly neurological, okay, then respiratory, rashes, tingling sensation, okay, picking needle sensation. A lot of people come with that also, okay. So all needs evaluation as long COVID. I'll just skip this. Now, mucormycosis, I think again, this is just an anticipated number based on May 22. The cases are increasing. So I think again, there is a case, but you need to be aware about the complications of post-COVID. Similarly, multi-system inflammatory syndrome in children, MISC, okay, involves multiple organs. Now, preparedness and response, okay, we have seen what all ramped up, the facilities which have been ramped up. Okay, establishment of specific COVID health centers, COVID hospitals, planning for oxygen, creating oxygen express. Okay, the guidelines keep changing. Example, it was simple mask, now they're saying double mask. Okay, how to wear it, that also has been told. Okay, inside should be a surgical mask and the cloth mask worn on top of it, so that the surgical mask reaches at least till 1/3 of the this thing. It completely covers the face. Okay, so important helplines. This should be made available to the patient. Okay, Aptamitra 14410. Any patient suggestive of ILI, any symptom suggestive of ILI. Okay, it can be called 14410. 108 is the ambulance. Okay, any doubts regarding essential health services is 104, and complaints 1912. Okay, so some helpline numbers for now. Any patient with COVID, if he was requiring ICU care, okay, in a private hospital, if District Venlock Hospital is full, okay, any of the private medical college hospitals or any private hospitals, ICU care will be covered by Ayushman Bharat Arogya Karnataka. For this, there has been identification of Arogya Mitra in every hospital, every private hospital. So that person will facilitate the whole process. And from the last week, now this facility has been extended to every patient, not just severe COVID in ICU. Okay, even a patient who opts in for hospital admission, his cost also will be borne by the government under Ayushman Bharat. Public health innovations, I think I'll just go through it. Important things were tele ICU, digital innovations, eSanjeevani, it's a portal, okay, online consultation, teleconsultancy. There have been 5 COVID repositories. Now, yesterday onwards, there has been surveillance of wastewater, sewage water surveillance, because it has been seen COVID virus is eliminated in the fecal tract. Okay, so a lot of the countries which have controlled COVID well, they had a good surveillance of sewage water samples to estimate the spread and the genomic surveillance. Okay, so this has been launched in Karnataka. Now coming to COVID-19 vaccines, okay, though we have 4 main types of vaccines: genetic vaccines, which are mRNA and DNA; the viral vector vaccines, which we have got, the Covishield; the protein-based vaccines, okay, and the inactivated, which is there right now, that is Covaxin in India. Okay, so these are the 4 main groups: genetic, viral, protein-based, and inactivated. So how do they act? I think I'll skip this. So currently, almost 284 vaccines, either in the preclinical or clinical stages of the disease. Okay, 101 are in the clinical phase. And of interesting are the mucosal ones. The 7 are intranasal vaccines. Okay, obviously, mucosal immunity, if it is good, okay, the chances of protection will be much higher. Okay, so that is one important thing. Now, general safety consideration for these 4 viruses, you need to remember with inactivated viral vaccines, if at all, okay, they are not completely inactivated, any component if not inactivated, and this person comes in contact with the natural pathogen, the wild virus, okay, he can have something called a vaccine associated enhanced disease. Okay, although it is very rare, but there is a slight possibility. You need to be aware about this with inactivated vaccines. The live attenuated vaccines we have seen with OPV, okay, they can revert back to virulent strain. The viral vector vaccines, what are the problems with these viral vectors? Okay, so the source virus, so for example, right now the Covishield and Sputnik uses adenoviral vector. Okay, so the Covishield adenovirus is a chimpanzee virus, chimpanzee adenovirus. Okay, so there is no human exposure prior. Okay, but the Sputnik one is the human adenovirus. Okay, that's why for the first dose and the second dose, they use different adenoviruses. Otherwise, there is a chance, there is a slight theoretical chance that the vector itself will be neutralized if the second dose is being given after a span of 4 weeks. Okay, if the vector only is destroyed, there is no chance that the gene which the vector was carrying will induce an antibody response. That's why in Sputnik, the first and second doses are totally different, the different component of the virus. Right. There is a small thing about risk of mutagenesis, where the virus can get the DNA can get integrated into the host genome. Okay, there is a chance of return of vector to original virulence, and there is a risk of loss of genetic material. For protein-based vaccines, it mainly depends on the type of protein used. For nucleic acid vaccines, now this is very challenging because mRNA vaccines, the Pfizer and Moderna, have been questioned a lot. Okay, and there have been a lot of misinformations, and concerns also with the Pfizer vaccine. Okay, so there can be immune-mediated events also, and there is a chance of integration of these vectors into the host cell DNA. Now, the WHO has come up with something called a COVID-19 Safety Surveillance Manual. Okay, this is not just AEFIs, that is adverse events following immunization. They also monitor something called adverse events of serious interest. Okay, so one important event which was being hypothesized was the clotting risks. Okay, a lot of clotting risks which were seen especially in patients with thrombocytopenia. So a lot of countries actually said patients who had platelet count less than 50,000 shouldn't take AstraZeneca vaccine. Okay, but if you see the number, WHO is saying global number is 4 in a million. 4 in a million. Okay, you'll be surprised. This is 0.6 per million in India. Okay, so it's very, very small. We are seeing very small thrombotic events. Risk. Okay, so people were in panic mode. A lot of doctors I've seen who have started Ecosprin, Clopidogrel, Ecosprin AV 75 and 10. So actually, it was if we rely by the data, what is given by the AFI, National AFI Committee, it's very, very small. Okay, and if you see the thrombotic risk event, which COVID per se causes, 16.5%. Okay, so 0.0004 is nothing compared to the 16.5. Okay, and WHO in its pharmaceutical listing also has given it is just a pure coincidental event. Okay, so there is no risk of a thrombotic event. So which are the viral vectors which are planned to be used? The chimpanzee adenovirus, human adenovirus, Sendai, modified vaccinia, para-influenza, influenza, measles, rabies, vesicular stomatitis. Now you have to be very careful which virus you use in which geographical region. Okay, you don't want to use a vector which will have a high antibody response in that particular region and the host potential. Now comparing the vaccines. Now this is a very important question which a lot of people ask. Okay, so this is a wonderful paper what I got. Published in Lancet Microbe 2021. It's comparing the 5 vaccines. Okay, Pfizer, Moderna, the Sputnik, which was the Gamaleya COVID vac, Johnson & Johnson, Janssen, which is called the vaccine, the AstraZeneca Oxford, or what we are calling Covishield. So now, if you look at 2 things here, okay, we don't have Covaxin in this. I'll talk about Covaxin a bit later. So now, if we talk about the vaccine efficacy, okay, so people were relying on this. And that's why a lot of people have heard, a lot of doctors also saying we want to wait for Pfizer in India. Okay, but remember the relative risk reduction, what we are talking here in terms of vaccine efficacy is only in the study participants. Okay, so that was 95 for Pfizer, 94 for Moderna, almost similar. Sputnik, it was 91 after the 2 doses. 67 for Johnson & Johnson. Okay, and 67 for Covishield. Now for phase 3 trial is out for Covaxin, it's supposed to be 78%. Okay, but what is more important is we need to see the vaccine effectiveness. That is not the study participants who participate in the trial. If it comes out in the community, how much of the disease can be reduced by the vaccine. Okay, so that is given by some number called number needed to vaccinate. Okay, preferably the relative risk reduction should be as high as possible and the number needed to vaccinate should be as less as possible. So number needed to vaccinate basically tells how many additional people I need to vaccinate to prevent 1 additional case of COVID. Okay, so that is basically the absolute risk reduction, not relative. Okay, it's the absolute risk reduction which is in the community. Okay, so that is very, very important. So if we look at this number, it basically seems that all the vaccines are equally effective. Okay, and what we are seeing, with cases with the death audit, people who have taken 2 doses of the vaccine, and if it is more than 14 days from taking the 2 doses, completed the 2 doses, okay, they are definitely not getting the risk of mortality is almost 0. Okay, and they are unlikely to get a severe COVID. For that matter, even people who have taken, although we have seen few people who have taken 1 dose and had death and have had severe COVID also, but even if it is more than 3 weeks, okay, they may get severe COVID sometimes. Okay, but mortality is definitely less. With any of the vaccines. Okay, Covaxin almost it says 100% prevention against severe COVID with 2 doses. Okay, so that's now look at the few interesting data, the share of people vaccinated. So why one question was that can vaccines protect us against the pandemic per se? Look at the 2 countries which have almost controlled the wave, or the curve is almost flattened. Okay, the vaccination coverage is almost close to 50 to 60%. Okay, while Brazil, it is somewhere around 20%, and India is just 11%, 10 to 11%. Okay, that's a major concern. Yeah, number of vaccine doses administered per 100 people. Okay, we have, you can say for every, we are giving 1 dose for every 1,000 people. Okay, so that's a very, very small number. And if you are looking at the bigger numbers, okay, before that, how is the vaccine really protective? Yes, look at the CDC data of April. Okay, soon after vaccination in the high risk group, 65 plus, okay, almost 74% are vaccinated. Okay, the hospitalization has decreased by almost 7 times. It used to be 70%, now it is less than 10%. Okay. Now, coming to the vaccination coverage data, what is interesting to see is we have vaccinated less than 1/6 of our population. Okay, the same scenario is seen in most of the states. Okay, Karnataka is not an exception. Okay, even in Dakshina Kannada, if we see a population of 22 lakhs, okay, even including both the doses, it's somewhere around 4 lakhs. So that is just 1/6 of the population. Okay, how to vaccinate? I think everyone knows it. The self-registration.covid.gov.in preferred thing. Okay, preferred website, not to get fooled around. A lot of websites, fake websites are there. You need to create awareness among the people, not to get fooled by it. So self-registration.covid.gov.in. Enter their mobile number. They'll get an OTP. Okay, they can register for up to 4 people at a time. Okay, so newer guidelines like vaccinate elderly and differently abled as close as possible to their homes. Okay, the recent revisions, what have happened, okay, last month. So the gap between first and second dose of Covishield, which was initially 4 weeks, then it became 6 to 8 weeks. Now it is 12 to 16 weeks. So the person has to wait for at least 84 days from taking the first dose of Covishield. If they are COVID positive, okay, or if they have received plasma, or they are infected after the first dose, they have to defer for at least 3 months. Okay, they have to defer for at least 3 months. If any patient is hospitalized for any other life-threatening or serious illness, he has to wait for at least 4 to 8 weeks. Lactating mothers can take the vaccine. It's not yet recommended for breastfeeding mothers. No need of doing a RAT prior to any vaccination, and blood donation can be done 14 days after vaccination. Okay, so vaccine wastage is very, very important thing. Okay, so roughly Covishield comes as 10 doses. Covaxin comes as either 10 doser or 20 doser. Okay, so but in few instances we are able to vaccinate almost 11 or 12 people with 1 vial, although it's 10 doser. Okay, but in the earlier phases, when a lot of people had vaccine hesitancy, that is at the time of January. Okay, only even if 6 or 7 people come, we used to open the vial, and remaining 3 or 4 doses used to go waste. Okay, so this phenomenon is very, very important to prevent, because now it's a very precious resource. Now, how to tackle the vaccine shortage? Everyone knows about this. Most of the private hospitals are wanting to have the vaccine. People want to take the vaccine, but vaccines are not available to the private providers. Okay, government also it's available, because 50% is going as central government stock. Remaining 25% is allotted to the state government, and from the 25%, other private people can take it. Okay, now there is a lot of lobbying. You must have seen. Yesterday I saw 2 luxury hotels, okay, actually claiming that they have a COVID package which is available. So here hospitals and healthcare facilities are struggling. This is the other side of the systems and things in our country. So anyways, things apart from that, now it's almost told that we'll be having additional 60 crore of the vaccines. So there are a lot of vaccines waiting in the pipeline. Okay, the Zycovi-2 of Zydus Cadila is a plasmid DNA. Phase 3 is ongoing, likely to complete. Biologically, 2-dose vaccine. The intranasal of Bharat Biotech, it's again a vector-based vaccine. Covax of Serum Institute, it's recombinant vector vaccine. The first mRNA of India, the mRNA vaccine of India, manufactured by Genova Biopharmaceuticals of Pune. Okay, phase 1/2. That's what in exceptional situations they can combine phases of vaccines. That's what can be done, so just to hasten up the process. Okay, right. So additional 216 crores by December end is supposed to be available. So then obviously we can vaccinate a lot more population. Okay, so 138, a country with 138 billion population. So how to fight the infodemic? So best things, the numbers, what you need to remember: genuine government websites. Okay, Government of Karnataka Corona Help Desk. Okay, there is mygov.in. Okay, it's there in Telegram also. Okay, guide to address stigma associated with COVID, and the dashboards, state and national dashboards are very, very important. Spread positive measures, spread recovery stories rather than deaths. That's very, very important. I think I'll not talk about this. I had few examples, but it's okay. I think lack of time, I'll just skip this. Now, mental health is very, very important. I'm sure Dr. Smita will be talking on this, especially 3 vulnerable groups: children, elderly, pregnant mothers. We are seeing a lot of stress, and not to forget doctors. Okay, it's very sad to say most of the doctors crying, they have lost hope, what to do, what additional to do. There are some who have given up that people who are recovering on their own. We can't do more than this. That's a sad state of affairs if doctors start thinking like that. So this is which needs to be addressed. Now, one important thing about newer diagnostic and therapeutics, what I would like to tell you is a lot of things keep coming that this can replace RT-PCR, saliva-based test. So if at all in doubt whether it is genuine or not, look for 2 sites. One is the WHO ACT, okay, Access to COVID-19 Tool Accelerator, it's called. Okay, and the second one is the ICMR portal. Okay, so these are the 2 genuine sites which you can check to see whether it's good or not. Now there is an important game for you. If you are someone who likes simulation games, NEJM has come with COVID simulation games. Okay, it's an interactive primer. So something like this, it's free, of course. You need not subscribe, you need not have an account. Okay, so basically it gives you a clinical scenario. You can, if you have understood the natural history well, you can keep asking for clinical history, symptoms. Basically, it's like a medical training. Okay, so you can give a good amount of time for this and see what is done for the patient, he will improve, or what if done wrongly, the patient can worsen. Another important thing is the COVID-19 Elsevier Healthcare Hub. This is very important if you are searching for a lot of good articles, especially Indian data, maybe relating to vaccine, diagnostics, COVID syndromes, mucormycosis. Okay, good amount of data. So apart from WHO, Ministry of Health and Family Welfare, or reliable websites, I think this also gives a good amount of resources. So I would like to conclude with these 2 quotes. So I'll stop now. If there are any questions, I would like to take that.
Thank you, Dr. Sudhir, for that informative presentation. I believe that it has given us significant insight into our current situation right now. We all have a role to play during this pandemic and how it will be remembered in the books to come. It is important we recognize the impact a contribution can make to one in need. So if you haven't made your donation yet, don't miss out on this opportunity to help dissipate this pandemic. So we now quickly proceed to the Q&A section. Dr. Sudhir has been a professor in community medicine, and the years of experience makes him the ideal candidate for your questions. We've got a couple of very good questions today, so we'll just scroll by them very quickly. The first question says, there was an article on the Times of India saying that if you have contracted COVID-19, you only need to take 1 dose of the vaccine. Is that true?
Okay, yeah, it's a very good question. And if you look at scientifically, okay, this might be a scientific article. Someone with knowledge of science and epidemiology would have commented this. So if you look at theoretically, what's happening with the 2 doses? Okay, the first dose is priming your immune cells, the T cells and the B cells. Okay, this is what you have learned in microbiology, immunology, right? So when you are giving the second dose after a good amount of gap, okay, the antibody response, which would have started tapering off, now with the second dose, again, it shoots up. Okay, that's what you need. You need maximum antibody titer so that the memory cells are there for a long period of time, and the antibody titer is also effective. So theoretically speaking, if there is an active infection, okay, an active infection, it's as good or even better than immunity which is induced by the vaccine. Okay, so theoretically it can act like that. But what you need to tell is, if anyone asks you this question, they have to take both doses. Okay. The idea is we are not sure what sort or what degree of immunity is given by the natural infection now, because we are seeing reinfection rates also. Okay. So for the vaccine to have its effectiveness or to stand to the efficacy, what it is supposed to be giving, okay, it has to be both the doses. And one important point I missed, if I don't know whether I covered or not, the antibody response starts 14 days after the second dose. Okay, so there are a lot of people who say we got the infection 3 days after taking the vaccine. Is it because of the vaccine? Okay, it's more so likely because there is a lot of crowd now where you are waiting in a long queue. You're fighting to get your jab. Okay, you might have contracted during that time or when you are waiting for 30 minutes because if you're not followed COVID appropriate behavior. The vaccine doesn't cause infection. It doesn't give a RT-PCR report positive. A lot of doctors have also asked me, okay, will vaccine give RT-PCR report positive? No. So the answer specifically is both the vaccine doses are important. Okay. Yes.
Okay. So the second question states about there are lots of misconceptions about this vaccination going around. Some of them think that they get a stroke. Some of them think they'll be paralyzed. Some of them think there are metallic components in the vaccine. So what is your response?
Yeah. So all the three vaccines which are currently available, okay, they are safe. I told you the risk what can be seen adverse events are mainly there can be pain at the injection site. There may be redness. There will be fever. Okay. Very rarely, what we have seen even with our experience in Father Muller's vaccination site, okay, very, very rarely we have seen a petechiae, or sometimes there was numbness or lymphadenopathy, which is very, very rare. Okay, so the risk of metallic component being there and all is without evidence. There is no biological plausibility which is to substantiate these facts that it can cause to any other severe grave complications. I told you the risk of a thrombotic event like a stroke or something in Indians, it's almost 0.6 per million. Imagine 0.6 per million. So that's totally negligible. The risk benefit analysis is in favor of the vaccine. Yes. Sorry. Yeah. Please.
A complete myth, and it should not be proceeded with. Okay.
Yes.
Drugs like Indevimab and Casirivimab are being sold at a cost of 59,000 rupees. Drugs like the Kovid cocktail. So how will the common man afford such drugs? And is it a major risk factor for various socio-economic classes?
Yeah, first of all, see, where are these viral monoclonal antibodies used? It's mainly used for mild and moderate COVID. Okay, so if you ask me if vitals are monitored properly, and if the three important things for any viral disease is done, that is, I told you, plenty of oral fluids, antipyretics if there is fever, and rest. If these three are done, no need of a cocktail of 60,000 rupees. People who afford probably will try that. It's basically like how remdesivir and tocilizumab were going, almost 6 lakh per vial, 60,000 per dose for remdesivir. So these are all the things which will be happening. And with all patent rules and other things, you can't blame the pharmaceutical company also at times. But the science will prevail unless it is affordable. It's not a drug which should be coming in the that's why you are not seeing the viral monoclonal antibody in the treatment guidelines of Ministry of Health and Family Health.
We also have Nicole ma'am asking in the comments section, is there a pharma lobby related to this?
A pharma lobby is there in every outbreak or every disease for that matter. But see, if you ask me, viral monoclonal antibodies as immunomodulators, they have shown promising results for mild and moderate disease, especially reducing the viremic load. So evidence says they have a role, but how much of a role is it needed for everyone? That obviously, as you rightly pointed out, 60,000 is someone which not all of us can afford. Even I can't afford 60,000 for a drug which is of 1,200 mg. So there is no point talking about it. Pharma lobby will be there, but hopefully after the period of time, this thing can be controlled.
It is seen that some medical professionals are taking Covaxin, even though they have taken both doses of the Covishield vaccine. Is it really to enhance their immunity, or what is your comment on the situation?
Yeah, so there is no necessity to take Covaxin. This even I have heard to tell first. Actually, there is no chance. There was no chance. This has been debated in a lot of our vaccine groups, because Covaxin was mainly prioritized for the people who are taking the second dose. It was not available for the first dose. So how people have availed Covaxin first dose will become interesting. And definitely there is no point in taking 2 doses of the vaccine. Probably I would say, when you're taking vaccines, when we don't have data, reliable data on efficacy, so there may be chances of a few adverse events which need to be taken with caution. So what you need to recommend is, if people ask you whether we need to take Covaxin, a lot of people are favoring towards Covaxin because the side effects, what you are talking, is not there with Covaxin at all. So that is one reason. Plus the interim data which came with the phase 3 study said 100% preventing against severe COVID. But Covishield is also equally effective. That's what I want to tell. It's said to be protective against the variant of concern. That's the vaccine which is supposed to be saving the against the B.1.617.2. So what do you need if you have taken this vaccine then? What more do you need? Yeah.
Right. So
Yes.
all the discrepancies regarding different vaccines are all fake, and we must all can choose any one of them. It doesn't really matter.
Yes.
All right. With the possibility of a third wave suspected in late September, are we equipped to face another lockdown, especially with the change of our health minister, the head of Narayan Health and all that? Are we really equipped to face another lockdown? And it is also said that the third wave is predicted to affect children. What are your thoughts?
See, all these third wave things and all are speculations. I personally feel we should be planned for any wave or any number of things. That's the most important thing. Our healthcare system needs to be prepared. What we are seeing is, after the first wave, we were very relaxed, and the same thing can recur. Now we may be prepared for September, October, and if we are relaxed, the third wave may strike us in January, okay, or February. So not to be relaxed, be alert, be aware what can happen. Okay, there are no evidence to suggest it will be affecting only children. Okay, children are already affected. If you just have a look at the first wave and second wave numbers, children were, the first wave, almost 2% of the children, the proportion affected was 2% children. Okay, now in the second wave, the proportion affected is around 14%. Okay, that's a big spike. And add this proportion to the absolute numbers. Okay, the first spike, our number, you saw the wave. Okay, the number of active cases was very less in the first wave. Okay, second wave, or the peak, what we have seen, we have almost 3 to 4 lakh cases every day. So imagine 14% in that number. Okay, so a lot of children would have been affected there also. And now I would like to tell one important Delhi serosurveillance data was out. And it showed 37% was the seropositivity in children, okay, as compared to 27% in adults. So that basically means more children were affected, which is expected with respiratory infections, respiratory viruses. Okay, so children being vulnerable definitely cannot be denied because they have not received the vaccine. But the third wave being exclusively in children is, I don't think there is any substantial epidemiological basis to say it's exclusively for the children. As against, I told you, probably if it has to happen with the almost 65% of our population in rural areas, we need to be prepared more in rural areas. Okay, so what test what diagnostics we can do, what treatment we can do, how our PHCs can manage moderate cases, how to refer them promptly, that needs to be planned further.
Right. Okay, so the time with the complete disorganization of our vaccination schedule, different patients, different people have been vaccinated in different time intervals. There are doses which there's a time difference of 28 days, 45 days, and 90 days between the two vaccinations. Does this really matter? Does this really differ? What is the based on?
Yeah. So what you need to remember here is, when we are recommending a vaccination schedule, okay, if you remember from what we normally teach in immunology and vaccines in third year, we say the minimum gap interval should be preserved. That is, now if I say the duration between 2 doses of Covishield, Covaxin, or Sputnik, okay, for Covishield, Covaxin, we say minimum interval is 28 days. we cannot give on 27th day, okay, or 26th day. But if you are giving it on, if you are giving Covishield on 84 days, 90 days, 116 days, or even more than that, probably what we see as the days increase, the antibody response, the immune response also will be higher. Okay, so say for Sputnik, it is 21 days, the gap between first and second dose. So again, you need to remember it can't be given on day 19 or day 20. It has to be minimum. The minimum duration is important when we are talking about 2 doses. The maximum doses actually doesn't differ. Okay, so if I had a chance, I would have also taken, I have taken on 28 days, 0 and 28 Covishield, but I had a chance, I would have taken probably at 56 or 84, nothing would happen. But whenever you are due, please finish your both doses of the vaccine, because I told you with the new COVID, the new variant, what Indian variant of the, sorry, again, we are not supposed to use the Indian variant, but the variant of concern, what is there in India, what we have seen is one dose gives you about 30% protection, okay, against the severe disease. When you are taking both the doses, the protection jumps to 82% against severe disease. Okay, so whenever you are due, please complete the vaccination. Please complete the vaccination statement. That's it.
Right. Now we have a very controversial question. The recent debate on allopathy versus Ayurveda has brought out skeptics on both sides. What are your thoughts on this?
See, as allopathy, or the term itself is very controversial, allopathy or mixopathy. These are the terms which we are used to using it. Better is modern medicine or ancient traditional medicine or Ayush, whatever it is. See, each system has its advantages. People have faith in different systems. Okay, so you can't play with the people's belief or what they are being taught from their grandmother or parents or things like that. So I don't deny the role of traditional medicines and use in COVID. Okay, they have been used as immune boosters and all. But at the same time, you have seen, especially I think other day ILBS, there was a talk, and Institute of Liver and Biliary Sciences, which is a premier institute for liver diseases, and they said use of giloy. Giloy is a traditional remedy. I think it's called in Kannada. I forgot the name. Anyways, if you search giloy, you'll get to know. It has brought in a lot of drug-induced liver injury. Okay, so patients normally think Ayurvedic medicines are without any harm. The only difference is, when you look at the data, the modern medicine gives data saying the most important causes of drug-induced liver injuries are antibiotics. We have data with that. Okay, but basically at the end of the day, more so cases of liver injuries or kidney injuries which are coming to hospitals, there are a substantial evidence, substantial number of cases which are because of traditional remedies. So you can't deny the role of the harm which these traditional herbs and remedies can cause. But if they are used to their full potential, like you also, I'm sure you guys also use some traditional remedies at home, thinking they are safe, but it shouldn't exceed a certain amount. Okay, if anything about recommended thing, that's what pharmacology says. It can be a poison. So rather than seeing the weaknesses, we need to see the strengths. Okay, what people are comfortable with. We should be, as modern doctors, at least I feel we should be sensible messengers. Okay, rather than criticizing a system, we should give proper evidence. Okay, and if there is evidence, we recommend a drug or we recommend a remedy. If there is no evidence, you tell them that it doesn't work. Okay, so right now, that's what happens with traditional remedies. You say, if you're getting some amount of, it may be physical, mental, whatever, okay, you can continue to take those herbal remedies, but what will they do for COVID per se? Obviously, there's no data or evidence for that. Yeah.
Right. You wouldn't discard Ayurveda completely as a field of medicine, but you would take all the points and the positive insights of it. And
Definitely,
if you ever can contract COVID, your best choice wouldn't be Ayurveda at the point.
Definitely no. So that's what you're seeing. No, these people who are criticizing modern medicine, once they get COVID, they are in a allopathy hospital or facility.
Right. Yeah. Since we are at a time constraint, we will jump to our last question. This question is the same question that is in the minds of many. It is what the answer we all want of. when will we go back to our regular life? And is large-scale vaccination our best chance?
Okay, that's a question which everyone is anticipating, and the answer even I don't know. We may have this virus probably will be internalized. So what we have seen with the previous pandemics, there may be post-peak or post-pandemic waves of the virus. There are a high possibility of chances. So we don't know. We don't have any substantial evidence to say when this will end. When can we have norms like a pre-COVID era? So very difficult. Is vaccination the only solution? No, vaccination definitely will not be the only solution, because we have seen that vaccines are not 100% effective. They are leading to infections, and as I told you, there may be chances of reinfections and breakthrough infections with new variants. So we need to be prepared for that. What we need is good amount of ground data, good surveillance, and especially community-based surveillance activities, because the data what we get right now also is limited in it may be quality or quantity to hospitals or healthcare facilities. But as I told you, almost 80% of them being mild or asymptomatic. And imagine roughly, there are a lot of speculations what can be the true number. There was one epidemiologist who said multiply the total number of cases by 30. Okay, I showed you in the initial pictures itself. Imagine only southern states are having COVID. Why you are not expecting the northern states? Is it actually COVID hiding from these, or is it bias? Or because there are no healthcare facilities, is it missed over there? The diagnosis is missed. We don't know. So that's why we need good amount of data, good quality data. So it may be through sero surveillance or anything like that. But till then, I think more than vaccines, we have to interrupt the chain of transmission. I'll go back to our epidemiology basics class, where we say reservoir. If you can't eliminate the reservoir, you see, can you protect the susceptible host? If the protecting the susceptible host is not foolproof with the available vaccines, the only thing which is left to you is interrupting the chain of transmission. Okay, and the chain of transmission can be interrupted with COVID appropriate behavior.
Thank you, sir. Thank you, Dr. Sudhir. You have been very enlightening to us all. And I think we have all been prepared to face all these questions from our general public in a better and more efficient manner. Thank you so much, sir. Now I would hand over to God.
So thank you so much. I'm sure this was a very enlightening speech, and most of us who are present here today definitely feel like we've taken necessary steps with your help to fight this infodemic. So once again, I'd like to thank you, sir, for sparing time for us today here. With this, we come to the end of today's session. I'd also like to thank once again all the dignitaries who are present here today, or even those who weren't present here today, but continue to guide us and enable us to make sure that this fight against the infodemic was a reality. So a gentle notice that all those who are present here today, you will receive an attendance link on the chat box, which will be sent right now. And we request you all to make sure that you open this link, which will direct you to a Google form, and you fill in this form. It's to show that you were present here today for this session. Also, please note that to receive the e-certificate, you must be present for all the 4 sessions. Thank you so much.
I just have one small point. Sorry, before you conclude.
Yes, sir, sure.
Thing is, I think I'm sure there must have been much more questions. I'm seeing a lot of questions in the chat box. So if at all it's not getting addressed in any of the future sessions, you can actually post it to me or any of the other speakers. We will try to answer. We don't want the students, especially medical students, to go with queries, especially relating to COVID, anything relating to COVID. Okay. Just pass on to me or any of the speakers at the end of all the 4 sessions.
Sure, sir. Thank you. The attendance form will be sent on the chat box, so kindly please have a look at the chat box. Additionally, I'd like to bring up another gentle reminder. This event is a fundraiser as well. So any and every donation made would be donated off to the Poor People's Fund, and it'll help treat poor patients in the Father Muller Medical College Hospital. So I kindly request everyone here present to be generous. Also, please note that we will have 2 speakers speaking tomorrow as well, which is a part of this workshop. The same timings, 5 p.m. And I please urge you all and request each and every one of you who are present here today to spread the word around so that we have maximum participation, so that more people are aware of what's going on. Thank you so much. Apologies, it's not 5 p.m., it's 10 a.m. Apologies once again. Tomorrow's session is not at 5 p.m., but it's at 10 a.m. The attendance link has just been put up on the chat box, so please fill in the form. Once again, the attendance form has been put up in the chat box, so I kindly request you all to fill in the attendance form. Also, please note that you will have to be present for all the 4 sessions to ensure that you get the e-certificate. So I kindly urge you to be present for all the 4 sessions. These sessions are very informative, they're very interactive. So please make sure that you're present here tomorrow and for the other 2 sessions on 5th and 6th. Also, I kindly request you all to spread the word around to your family members, to your relatives, to your friends. That they can also watch the workshop. The workshop was streamed live on YouTube, so y'all can share this YouTube link with them and they can be a part of this workshop as well. Thank you. With this, I'd like to sign off for today. Thank you so much for being here. Once again, thank you. And I'll see you all tomorrow.